This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. Today, we're highlighting an article that was recently published in Neurology in Clinical Practice called Using Design Thinking to Understand the Reason for Headache Referrals and Reduce Referral Rates. With me to discuss is the lead author, Ashish Patel, who's a senior resident at Geisinger Medical Center in Pennsylvania. Congratulations on your paper.
Thanks for having me on the podcast.
So why don't we start with the purpose of your paper? I mean, it's kind of obvious. Headache is a top reason for referrals, but tell us what you were thinking and you and your team.
We found that the number one reason for referral to neurology was headache, and we wanted to improve access to headache care at our institution.
So why don't you tell me a little bit about your methodology? I understand that you got a group together to discuss issues. Why don't you tell me about that?
We had different stakeholders in this process. One were the primary care providers and advanced practitioners in the family practice. But we also had clinical pharmacists and informaticians at our institution. And so we got this group together to figure out ways we could improve access to headache care and what were the barriers that prevented this access in the first place.
And you used a design thinking process. What is that and how do you use it?
There's 5 steps in this design thinking process. The first is to empathize. And we found that when we talked to these stakeholders, their main issue was that they couldn't get their patients in to see us. And then when they did get their patients in to see neurology, they just did not feel like we had addressed the initial concern. So that's the first step. And then the second was to have these stakeholders clearly define what the problem was. And from their perspective, they didn't have time to sometimes address this concern in their office, but also then when they made the referral, it was difficult to get their patients to be seen in a timely fashion. And then third in this process was each one of these stakeholders threw out different ideas for solutions. And one of the things that they told us was that they wanted to do the thing that was right for the patient. And optimally, they wanted to even have a neurologist directly there in their office to ask them in real time what they should be doing for them. And then fourth in this process was to create a prototype. And so we thought that out of all of these ideas, it would be great to have a neurologist in the office itself, but that clearly wouldn't be practical. So we came with a different idea of maybe using the electronic medical record to have a tool that the provider can use in real time to help nudge them towards doing the right thing that they had said they wanted to do. And then fifth was formally testing this tool in practice. So deploying the tool in the electronic medical record and assessing how it changed practice patterns.
So that sounds like an intricate process. Why don't you tell us a little bit about this best practice alerts that you implemented and some of the tools?
The best practice alert is essentially a clinical decision support tool. So when a diagnosis of headache is entered into the medical record, this pop-up tool comes up on the screen. And it nudges or reminds the practitioner to see if they've asked particular questions. And there's checkboxes. So things, for example, including red flags in the patient's history, clinical features of the headache, such as light or sound sensitivity or nausea, any disabling intensity of the headache, how frequent these headaches were, and if medications had been used, preventives, abortives, and nutraceuticals. And then there were other steps within the tool. So after making the diagnosis, there was also a treatment dialog box that came up. And so in that treatment dialog box, during the design thinking process, our PCPs had told us that they wanted something that was quick and easy to use. And so we wanted to make sure this tool could be completed in under a minute. And so after they had checked the appropriate boxes, it came up with possible treatments to consider, such as preventives. And based on either the patient's comorbidities, it allowed you to choose the appropriate preventive treatment. And then third, there was a dialog box for imaging. So it had checkboxes for MRIs or CTs. And based on the patient's comorbidities and other red flags that may have been already highlighted, it nudged the provider to either order or not order imaging.
And were these things that the provider put into the tool, or was it extracted from the actual note or problem list?
This was something that the provider put into the tool. So the best practice alert came up, there were check boxes, and the provider would just click on those boxes.
So why don't you tell us a little bit about the impact of this tool on care delivery in primary care clinics?
We found that when the tool was deployed, it was only used about 5% of the time because it wasn't a hard stop. It came up and they could dismiss the alert. And only about 5% of the time was the tool actually completed. But nevertheless, we found that there was a huge reduction in the number of referrals and MRIs that were ordered both prior to and after the deployment of the tool. So we found that of 986 patients that we looked at prior to the tool, there were about 332 referrals. And then after the tool, we looked at 874 patients, and we found that yet only 76 referrals to neurology was made. And so that was a reduction by 77% in referrals to neurology for headache. We also found that MRIs were dramatically decreased as well. So we found that prior to the tool being used, in those 986 patients, 77 times MRIs were ordered, compared to after the tool, in those 874 patients, only 50 MRIs were ordered. So that was about a one-third reduction in MRI.
And so were you able to look at things like evidence-based medication prescriptions? And I know that you did not capture the patient-reported outcomes.
While the referrals decreased and the MRIs decreased, we didn't see any change or any significant change in prescription management by the PCP. So we didn't see a significant change in the number of preventive treatment that was ordered by the primary care doctors, nor was there a significant change in abortive treatments offered.
And I know that you were able to show some pretty big cost savings.
If you look at 77% reduction in referrals and 35% reduction in MRIs, we were able to multiply the average number of patients seen by our PCPs in 3 months, which is 930 patients, and we used the reduction in consultations, which was, we estimate, about $550 per visit, and MRI scans at about $2,000 per MRI. We identified over those 3 months in 930 patients about a $200,000 reduction in costs. So over a year, that came out to about $830,000.
So it sounds like this was pretty successful in reducing referrals and reducing imaging rates, as well as saving money. Tell us about some of the limitations of the study.
Yeah, and so some of the limitations with this was that we didn't assess for patient satisfaction or treatment response. So it's unclear to us if the patient's symptoms improved and if they were satisfied with no longer coming to see neurology and having their headaches treated.
And what's the next step for this study?
Our next iteration is going to be assessing the effectiveness of this tool on a system-wide level. So we're actually employing a cluster randomized trial to look at that. And we're also considering using this type of tool in other domains, for example, low back pain or neuropathic pain. But I think we have to be mindful not to disturb primary care providers' workflow all that much if for every diagnosis a best practice alert were to pop up.
And you mentioned that the tool rate was very low in terms of engagement. How do you think that could be improved?
I guess the question here is, does the engagement with the tool necessarily have to be improved? It depends on what the purpose of the tool is. In our case, we wanted to shape the demand for neurology services. And so even though there's only a 5% use of the tool, it dramatically shaped the demand for neurology referrals by 77%. So I'm not sure if increasing engagement with the tool is necessarily needed to meet our aim of this study.
Maybe just that big brother being there just changes behavior, at least temporarily. We'll have to see with a follow-up study.
That's right.
Well, congratulations. I think this is outstanding work, and I think that, we're dealing with a huge workforce issue, and these are the type of practical studies that we need. So congratulations. And thank you for listening to the Neurology podcast. Do check out the article.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.